Hello, everybody, and welcome to this next episode of the Akkad and Coca Report. Thank you for joining us. I'm Michel Akkad in San Francisco, and with me is my co-host Anish Coca in Philadelphia. Now, regular listeners and viewers of this program probably know that we favor voluntary, decentralized, free market solutions to our healthcare problems. Today, we will demonstrate that we are more than willing to invite guests who do not share our perspective. In fact, if you subscribe to the show, you will realize over the course of the next few weeks that we are very ecumenical and always eager to dialogue with our ideological opponents. Our guest today is one such opponent. He is a financial analyst at NYU working with research grants. He graduated from NYU with a Bachelor's of Science in Finance and obtained a Master's in Public Administration in Healthcare Policy, in the course of which he worked on emergency department care management models and on comparative analysis of healthcare systems, studying in particular the healthcare systems of New York and Quebec. He is currently applying to medical school, so we are hoping to intervene quickly here and prevent his anti-free market ideas to become solidified, because we are keenly aware that medical schools are not places where the virtues of free markets are extolled. With us is Roman Zamishka. Roman, welcome to the show. Did I pronounce your last name correctly? Zamishka.
No.
Zamishka.
Zamishka. Yeah.
Roman Zamishka, welcome to the show.
Thank you.
Well, before we're delighted to have you. Before I tell the audience why we have you on the show, I want to urge everybody to go to the show notes, and it will be I believe it will be episode 22, whatever episode it says at the beginning of the show here. But Roman has put together the funniest video meme about Obamacare.
Was I already on this show before?
No. I mean, we will put that on the website. We will put a link to the video meme that you have of Obamacare, which is absolutely the funniest, the most hilarious thing I've seen in a long time. But so Roman, you wrote recently on your blog, and then it was posted on the high traffic healthcare blog, an article entitled "A Libertarian's Case Against Free Markets in Healthcare." Now that's provocative and paradoxical.
I've already been excommunicated.
Right, but no, here we are.
I took my card last week.
But not only are you attacking free markets, but you attack, my very co-host here, Anish Coca, for being, supremely naive to think that free markets can provide solutions to healthcare. So go ahead, Anish. Go ahead. Defend yourself.
So this all started with us, Michelle and I, having Keith Smith on. Keith Smith is an anesthesiologist who founded the Surgery Center of Oklahoma, and the Surgery Center of Oklahoma is kind of a symbol of what the free markets can get you in healthcare. It's a independent, freestanding hospital, if you will, where you can do where you get tons and tons of elective procedures, and there's a cash price. You go on a website, there's a cash price. Patients pay cash up front. It doesn't matter if they stay 2 days, it doesn't matter if they stay 4 days. The prices are fractions of what the hospital, that is blocks away, charge. And so it seems like it's an example of the free markets kind of allowing you to have your cake and eat it too. We're told a lot about trade-offs in healthcare and how you can't, you either have to ration or you have to pay exorbitantly high prices. And here, you can get a cholecystectomy for one fifth or 1/10 the price of the local hospital with quality that's the same. And so, I pointed to this as me and Michelle pointed to this in the episode as an example of how free markets can work in healthcare. And I specifically wrote, in the medical economics blog about the fact that frequently people in the United States and people around the world look to the United States as an example of healthcare and free markets not working. So that if you have free markets healthcare, you get what you have in the United States, which is exorbitantly expensive healthcare. And on top of being exorbitantly expensive, spending 18% of the healthcare and GDP, we're not able to cover and give access to everyone. And I made the point to say that, what we have in healthcare is absolutely not the free market. We have we have crony capitalism, where you have the government intervening to create large monopolies, which then allow for crazy outlandish pricing schemes, which then bankrupts the nation. So I said, look, the Surgery Center of Oklahoma is the way to go. This is an example of the true free market. And Roman, as Michelle's alluding to, wrote back in response and saying, as a libertarian, arguing why I wasn't getting the whole story. So Roman, give us your rebuttal.
The rebuttal is basically, if you look at the literature and the way the debate goes on normally, is on one side you have the Boston types, is what I call them in the article. It's the healthcare as a human right people who want all healthcare provided by the government. Then you have the economists, sort of like Chernev and Ashish Jha and Harvard and so on. They're more middle of the ground, and they're going to argue along the lines of welfare benefits for everybody in terms of maximizing economic welfare, and talk about asymmetries in decision, moral hazard, etc. And they will criticize free markets from that perspective, saying there's problems with people selecting themselves, knowledge issues, etc. Some of it can be a little bit patronizing, along the lines of patients don't know what they're shopping for, therefore they can't shop. I don't regard that as a legitimate argument. But then you have the libertarians who will argue generally, well, we have all of these anti-competitive structures in healthcare today that are preventing us from implementing cheaper, more cost-effective quality healthcare today. And what I would try to argue, and that's what I did in my piece, is that there are structural problems with healthcare and how the nature of disease and how disease occurs and how emergencies occur and so on that actually prevent a lot of healthcare from being free market. So, for example, the very first one of my examples was the emergency room. If you are in an accident, you cannot shop for your services. We can talk about the freedom to choose and the importance of that, and how that drives better services. But at that moment, you literally cannot shop. So everything has to be premeditated upon that. You have to be prepared. So now you have insurance and so on.
So that's one that's one good point. So Michelle, tell us, what do we do with?
Of course, that's classic. The classic, it's a classic argument. You make it very well, Roman. What if you got hit by a bus? You're unconscious. You can't shop. But you don't have to shop for the exact procedure that you have. All you need to say. Now, of course, there will be exception, but for the most part, all you need to say is, take me to X hospital X because I know they have a good reputation. They are fair. They've been in the market for a long time, and I trust them. I trust them, and that trust builds over time from prior experience, and there's no reason why that wouldn't be sufficient. Because if there is truly a free market, hospitals would be competing, and the greediest one will be outcompeted by the fairest one, because the economic value of greed is zero. There's zero value to being greedy in a free market. Because over time, customers, because not everybody will show up unconscious, people will show up no matter, or if somebody shows up unconscious and they get fleeced by the hospital, the word will spread. The word will spread through the community that this hospital fleeces patients who are unconscious, and that's a very bad thing to do. And the word will go around, and people will not go back there. So you don't have to say, "Oh, I have a comminuted fracture of my femur, and I can't shop, and therefore I'm completely helpless." You can say, "Look, Mayo Clinic, and here I'm referring to the Mayo Clinic from the turn of the 20th century. They were much cheaper, they were much better quality. They were very pro-patient, and everybody knew it. And you say, "Oh, take me to the Mayo Clinic," and that's all you need to to say. And nowadays you can have it tattooed on your chest if you want. Whenever I'm unconscious, take me to, hospital X, which I think is the best hospital.
My concern is that we know that surprise billing is already a problem. And it's routinely done by, I'm not going to say with 100% certainty, but I'm sure every hospital in the country does it.
But of course they do. They do it because they can get away with it because they are.
But that's the point. This information is not exactly hidden. Patients are affected by this on a daily basis. And somehow this has not damaged their reputations. It doesn't matter if you're a small hospital in the middle of Arkansas or if you're in the middle of New York City. All of them do it.
Right. Anish, you want to respond to that objection?
Yeah, it's interesting. When I started a little solo practice in the heart of Philadelphia, surrounded by, there's like literally a cardiologist every 10 steps you run into a cardiologist in Philadelphia in Center City. and it's a very competitive environment. And I've told, I don't know how many referring doctors in my little 5-block radius, when asked, it's like, this patient doesn't have insurance. Will you see them? And I have one answer. Yes, I'll see them. One, of course, there's some degree of altruism in that, you don't want to turn away patients that need help. But number two, there's a business reason too. If I say yes to a certain provider who's sending me patients, they will send me not only their patients that are uninsured or underinsured, but they'll also send me their other patients, right? It just generally builds a good reputation to be regarded as somebody who will see everyone. And so as a young guy with like zero, my dad's not a physician here. I have no connections. The only way to get patients is to be the most accessible guy around.
Right.
So that's one. Two, this billing thing, this surprise billing thing, I haven't dug into it a tremendous amount to truly understand. I understand it, but I can't run a practice like that. When I send out, I do my own billing, and if I suddenly started sending patients bills from Coca Cardiology for exorbitant sums because they're out of network, I'll never see them again. I will develop a tremendously bad reputation. So, I've never ever sent.
Roman's point is that you may be an exception, but most hospitals do that, or have done.
I think it's also important to recognize.
So the reason that is, so getting to my point, the reason that is because in hospital systems have kind of insulated the billing side of things from the physician. So the physicians are able to wash their hands of anything, right? So a patient comes in,
Sure.
the doctor does the cath, saves the guy's life, and then he washes his hands of it and walks away. Meanwhile, the administrative side, so the billing department sends some $50,000 bill because the guy's out of network, and the doctor says, hey, it's not me, it's somebody else. So when the patient has no one to come to. For me, if I say, I am everything. Like I'm the one who sends out the bills. And a patient comes to me and says, what the heck is going on? Like there's some accountability here that I have that physicians in employed large health systems do not have. So therefore, the physicians in employed systems or even large multi-specialty groups are able to escape that and say, oh, it's not me, it's the billing, and these guys, I'm really sorry. They shake their head, and about this terribleness that's happening, and it's not under our control. And that's terrible. And I say all the time, it's physicians abdicating their responsibility to the patient. It's not enough just to do the procedure. You also have to be responsible for any financial toxicity that you may be causing the patient. And we've lost that over the last 50 years. So if we moved, I agree with you, Roman. But if we in what exists now, that there's this lack of culpability that physicians are able to have, but in a better system where physicians own facilities, like the surgery center of Oklahoma is not going to be around very long if they're randomly sending massive bills to X, Y, and Z. So in a different system, perhaps you don't have these issues.
So couple of points. The first one being, what's important to recognize is that you value your patients from a clinical perspective, from a human perspective, and from a business perspective, because you need them to come back for repeat business.
Right.
What's important about the emergency department, for example, since that's the one we're talking about, is they don't necessarily want repeat business, and they necessarily get it. How many life-threatening emergencies do people have over the course of their life? You know, if you have one, that's bad luck. If you have two, that's very bad luck. So this idea of repeat, reputation and maintaining a high quality that's your patients remember about, they may just not care about it. And if somebody got screwed for $50,000 or whatever because the surgeon happened to be out of network, that may not adversely affect them in the long run. Now, I understand there are effects of aggregate reputation where, you go and complain and et cetera, but the point is that that's the environment that we live in. We already live in this pseudo free market environment, not a true free market, but the point is that these events occur. And I understand that I think Vox is doing their big annual project trying to expose these things. And I'm curious what will happen at the end of it all, because it sounds like they're going to unleash a big stash of these stories.
Yeah.
But how many institutions will be damaged by it? How many institutions will stop doing it? How many institutions will ensure that all of their physicians are within network of the insurance plans that they work with? And it sounds like none.
No, but Roman, listen, you take as a reference as if, the system in network, out of network, all of this whole business of in network, out of network, all that stuff, all this we're talking about a completely corrupt, I call it the government insurance system, because even private insurance companies would not survive and have been subsidized by the government for the last 70 years. So the whole system is anti-free market. The whole system is a system of subsidies and regulations. So when I'm talking about the free market, I'm talking, you get rid of all of that, and you let the patients, the primary people, who are the recipient of the care, make the decisions and decide with their money, with their dollars, where they're going to go. And at that point, I can guarantee you that it's logically impossible for hospitals not to respond to the need of patients if those patients are truly in charge of their healthcare. And that's what the free market is. It means putting the responsibility for the healthcare back to the patient.
The problem is, I think, Michel, the problem is, how do you get there from this crazy system?
That's a different, right? But let's at least first agree that on principle it's a better system.
I agree.
If we start to agree that, so then the question becomes, well, it's a pragmatic question. How do we get there from here, right?
So in principle, on a theoretical level, I do not disagree that
that was too easy. We're barely 10 minutes into the show, Roman, and you're already...
And I already gave up now. I don't think, in principle, on a theoretical level, I agree that a free market system would result in higher quality, more responsibility, et cetera.
Okay, but I want to address all the objections you have, not just emergency, because you go one after the other, and it seems that in your paper you make those objections on principle, meaning that on principle the free market cannot address. So first you start with emergency room. We just talked about that. Then you talk about pediatric care or child care in kids. But I mean that's the same. I mean there's no difference. I mean in a free market system where people are making their own healthcare decisions, on their own, they will be the value of reputation and service will come at a premium, and those entities that are greedy and that provide bad care will be outcompeted by hospitals and doctors like Anish here, who are not so greedy and are willing to provide good care, to infants, to everybody. I mean, there's no reason why. Part of the argument you make when you talk about child care, you're talking about the question of the safety net. If people who are so poor that they cannot afford, to go to a private hospital, and therefore, we need the safety net. But again,
not necessarily, actually.
Well, then expound a little bit. Why do you think that pediatric care is an exception to free market principles?
With pediatric care, my concern is mainly about agency and the fact that children cannot shop for their own insurance. And so it's possible for people to make substandard choices on the behalf of others.
Right, but that's true. That's in human nature. I mean, children are always dependent on their parents, and they don't make choices. They don't make autonomous choices until a certain age. I mean, it's true for the food they eat, for the care they get. So I'm not sure how do you go from there to the nanny state where we have to provide a system for pediatric care that is nationalized.
Primarily, it's a focus about, from a political perspective, of pushing through the libertarian ideas. Because ultimately, we can't say the free market will provide everything and then expect everyone to believe us. That's been the catechism for 50 years. And, you can go on YouTube and look up Milton Friedman at the Mayo Clinic, and he walks up and discusses the Mayo Clinic and how great they're doing, and the problems with the NHS, followed up by we need to get rid of certificate of need, we need to get rid of required licensing, we need to get rid of various regulations on drugs, and everything will be better. And what's been the story? Over the last 50 years, there's been retreat on every single front. Because libertarians like to argue from a very puritanical perspective. They want the whole pie, and everybody else will happen to enjoy it once it's cooked. And the reality is that the result of that strategy is libertarians just end up missing out on the politics, and they end up not playing the game. So on pretty much every front has been just nonstop retreat. I guess certificate of need laws have been repealed in certain states, but the majority are still in place. Medicare has expanded twice since the 70s, right? Medicaid obviously got expanded just within a decade. And the idea that we can get everything that we want without giving up stuff on other points.
Roman, I think it's kind of a straw man argument. I mean, first of all, I mean, it's clear that the movement in the last, 50, 70 years has been inexorably towards more centralization. At the same time, people are recognizing now that it's impossible to sustain and it's about to collapse. Number two, there are movements that are extremely hopeful, and Anish mentioned the one of the surgery centers, and the Oklahoma Surgery Center is one of them, but there are many others, and then there's the direct primary care movement that is extremely hopeful. So it's true that it requires an effort of imagination to imagine the free market, because it's completely foreign to our experience. We've all grown up in a very highly regulated and highly subsidized system, and it's very hard to imagine how it would be otherwise. But I think it's very, very important that when we talk about the principles, that we demonstrate that they are sound, and they are sound because at the end of the day, nobody can make a better decision for a patient than the patient themselves or their immediate personal entourage. People who have the most stake in the outcome and in the care, meaning their families, their friends, their communities. People, and
sure.
and any intervention, any government intervention is a departure from that. It's a minus from that. It's a negative on that. It means that decision making is taken away from the patients in some fashion, either by regulation or licensing or certificate of needs or subsidies that favor certain special interests, and so forth. So I think it's important to have clarity on the principles. Now once you have clarity on the principles, then you can say, okay, well, how do we get there? And the way we get there is by, waiting for the opportunity. Right now, there's an opportunity for surgery centers to provide free market healthcare, and they're doing it very well. There's an opportunity for primary care physicians to do that, and many of them are doing very, very well. And but we should be very careful not to say, well, the free market, just to appear reasonable and to say, well, we're not completely radical guys that are unrealistic. We need to acquiesce to some government intervention. The moment you acquiesce to some government intervention, that's it. You know,
So let me ask you a question.
Yeah, go ahead.
So you two are practicing, you do billing and so on. The private health insurance firms, how do they compare to CMS in your perspective, to Medicare? In terms of their, let's call it authoritarianism.
I don't
Are
deal
they
with
really
any
so
of them,
much
but,
more
so
benevolent?
I'll let Anish answer that first, and then I'll give you my perspective.
Yeah, because I'm not truly free market. Michelle is. I'm still sucking. Anyway, I'm still attached to third party payers. So commercial. There's commercial insurance, but you're saying how authoritarian are they? Meaning how willing are they to allow me to bill?
Well, how do you feel when you're practicing with them? When you're dealing with them, do you feel good? Do you feel like you have to fight with them all the time? Do you feel like...
Yeah, well, traditional Medicare, I do not, because traditional Medicare essentially, will give you whatever it is you want, though their reimbursement rate is lower in general. The commercial insurers...
Do you feel more free with Medicare or with the private insurers?
More
as a
free.
physician, in terms of getting the treatment that you want for
well,
your
it's all like different levels of... I don't mean to, I'm sure Mark Hufnagel will blow me up on Twitter for saying this, but it's all different levels of slavery.
Okay. But which one is worse?
Yeah, no. So ideally, I'd love to just deal with traditional Medicare, and I get whatever I want.
There we go.
I don't have to fight. But that's within the current system. Obviously, the best system, the one I advocate for all the time, is something like what Michelle is doing, which is essentially to deal with patients only. So that I acknowledge would be the best, most free system. And the problem here with dealing with traditional Medicare is that traditional Medicare, year to year, comes up with some different game that I have to try to finagle my way around, right? So suddenly there's MIPS, and if I don't do X, Y, and Z, and if I don't connect to some registry, suddenly next year my payments will be down 9%. So anyone that takes the long view of things realizes that traditional Medicare is not a stable situation that I want to depend on. So what am I trying to do? I'm trying my hardest to try to create a large panel of outpatients that I can somehow ultimately transition to something that isn't third party based, right? So that's there's no practicing physician who deals with the actual money part of it, who doesn't think that that's the solution, to have some panel of 600 patients that are paying a certain retainer per month for your services. That is the freest and best way to be.
Right, although I don't know that the retainer model is necessarily key to that. I mean, it can work in certain...
Or retainer meaning a monthly... What do you mean? What does retainer mean?
It doesn't matter which... It's between you and the patient, and it depends on what you do, and some activities may be more... better suited for. But
Roman, where were you going?
No, I want to comment on that here because let me comment on what Anish is. Anish is a subcontractor, and he has different contractors he can choose from. One contractor can be Medicare, and that's the contractor that leaves him alone, and except that once in a while it can impose certain issues, like MIPS and whatnot. And worst of all, that contractor sometimes can audit Anish, to make sure that the job has been done. Not that Anish has provided good care, but that Anish has provided, care according to the specifications of the contractor, which have nothing to do with good care. Another contractor may be, Humana or whatever, private insurance, and they pay better and so forth. But Anish, whenever he wants to do a project for that contractor of treating a patient, he has to provide justification, and all of that. It's a charade. It's a charade. It has nothing to do. The agreement between the contractor and the subcontractor have nothing to do with providing good care. The contractors couldn't care less, really, if the patients are happy or unhappy. I mean, how would they know to begin with? I mean, they have no idea. They can, they give out patient surveys and all that stuff, but they really don't know whether Anish has good bedside manners or not. At the end of the day, all they care about is that, Anish does as little as possible. and that's the situation in this government insurance system. So if we go all the way to a national healthcare system, which is what you advocate in your piece, it seems on the surface that everybody will be like traditional. The contractor will be like traditional Medicare, where they are not going to bother us so much. And
probably not. We know that.
But we know, yeah, of course, that's we know that, and then the worst thing is that Anish will have no choice whatsoever. So right now, if he wants to take care of his patients, at least he can play on these different contractors he's working with as their subcontractor. He can, diversify his income.
See, I think that's actually a huge problem, because there's this illusion of choice where all the choices are awful, and the private choices, even though we want them to be good, none of them are good. All of them are worse than the other alternative.
I agree. Here, you're talking about the private insurance choice.
Right.
Yeah.
We're not happy. Physicians are unhappy with all of them. By Anisha's own admission, Medicare is the least annoying. The advantages of going to a Medicare model is, even if they are more annoying, the first is just a simplification and harmonization of administration across the board. But I think one thing that's really underappreciated about libertarians is that, we always talk about the original sin of employer-sponsored insurance. I don't see any political way to get rid of employer-sponsored insurance without single payer or some form of federal universal healthcare.
I disagree. I think already the trend is already that employers themselves are getting rid of insurance, and they're self-insuring in greater and greater numbers. I mean, that's something that we've learned from our interview with Keith Smith. So in a way, there's a trend now. Self-funded plans are on the surface they look similar to private health insurance, the way they run. But over time, I think they will be more and more in touch with the reality of what care is. And certainly it's a little bit closer to the level of the patient, that if the employers themselves are directly, paying for the care, they're going to be a little bit more attentive, a little bit more demanding, a little bit concerned about, real cost effectiveness. Not as much as they would with not as much as the patients would themselves, but certainly it's the trend in the right direction.
Is it though? Because the insurance is still tied to the employer then, though. Like, we don't want that. If I want to be able to become unemployed,
I agree. Well,
without having to worry about my insurance.
Right. Well, right now, if the law allowed it, people could congregate into fraternal organizations. There are some exceptions to that. So there are some, the so-called cost-sharing ministries. So people can belong to a pool and say, listen, it's a pool. It's not insurance because there's no contractual obligation to pay for care. But we're like-minded people. We pledge to help each other out, and we put a little bit of money every month, into the pot. And then when somebody gets sick, then we take care of the problem. And I think
that's never going to be allowed. That's the problem, because the second you put it on top, the majority will say, hey, we don't want this. We want community-rated healthcare. We don't want all the healthy people going into the same community insurance that's based around a gym or a health club, etc. It's legally untenable. I wish it were. I agree with you. That would be an optimal solution.
I'm not sure. The ones that are allowed are busting at the seams with applications. I mean, I don't know. I don't have the details, but I know that they saw a huge growth when around the time that the ACA was passed. And go ahead, Sanish.
So I think the points that Roman I think is arguing again and again to say that this is not pragmatic, and that we're and that this is not, none of these solutions are tenable because the public is not willing to be sold on kids not having insurance. Because the moment that one child has a bad event because they did not have insurance and they had a mom that isn't your mom, Michelle, and did not take care of something, at that very moment, the counter reaction will be, oh my God, how could we let this happen? And there'll be, a demand for blanket insurance. But Roman, it seems to be that the problem is the problem. Maybe you guys can agree. Is the problem that we're not able to sell the public on second order thinking? And so if that's the problem, maybe we should be making our arguments better, as opposed to saying, well, the public just will never understand, and therefore, we can't do this. Because clearly, I mean, the point I've made over and over again is that our biggest problem in healthcare, in terms of access and giving access to as many people as possible, it relates to how costly healthcare is. And if you made healthcare, more free market, more driven in the world that Keith Smith would create or has created, you would actually have more people having access to healthcare than they do now. We are all poor because of healthcare, because of how healthcare is worked. So perhaps would you say, Roman, that what we have to do is not give in to this, not be defeatist and say, well, we're never going to be able to convince the public, but instead try to push and say, look, if we went to a more sane world, more people than ever would have access to more things.
I will give you an example and a counterpoint. Let's consider the case of Ukraine, where I'm from. If you go to Ukraine today, in theory, we have a universal healthcare system. The Soviet constitution, in theory, had universal healthcare, so the Ukrainians picked it up as well when they got independence. In practice, there is no such thing, as we know. It does most people no good. In theory, all the physicians are on state payroll. The state payroll is insufficient. So in practice, what you have is very much cash-based system, to a degree that may or may not surprise you. So when you go to the doctor, even though you go to the hospital, go to a primary, internist, etc., you supplement with cash. If you want to see them again, you especially supplement with cash out of pocket. But it goes further than that.
Is that against the law, or is that
in theory, it's against the law, but nobody polices it.
Sure.
Because the government knows that if they started cracking down on this, all the physicians would just leave. They would migrate to Poland. They would go to America if possible, UK, sure, etc. They would become the Balagarvas of the world. So everybody pays cash. You get home visits for cash. It gets worse though. You go to the hospital for a surgery. You pay cash. What does that mean? Not only do you pay cash to the nurses just for taking care of you. You pay cash just to have your bed sheets made. You pay cash to have the surgery done. Any drugs that are necessary pre-op or post-op, or even during the surgery, anesthetics, etc., you purchase by yourself at a pharmacy and bring to the surgeons to be used in the surgery. It's all in theory illegal. In practice, it is an extremely cash-based healthcare economy. Ukraine is not a libertarian healthcare paradise.
Yeah, of course not. Of course not. But again, we shouldn't confuse. I think these are very good points that you make, but we shouldn't confuse cash-based versus free market. Just because something is cash-based does not mean it's free market. And obviously, in Ukraine, you have all kinds of. I don't know the details, but all kinds of rules and regulations that prevent free enterprise. I'm sure you have a lot of special interests that are protected by the government, cartels, and so forth. I would imagine, and also, it's a poorer country, and it's a country that's still reeling from 70 or 80 years of Soviet domination, and so forth. But you're
that
right.
Sort of goes to the point that I don't think there's any libertarian paradise anywhere.
No, there's not. But
that's my point. There's many countries across the world, to varying degrees of development, that are largely cash-based because they don't have these robust welfare states. And we don't see a free market flourishing in any of them. That's a little strange, no?
No, it's not strange. It's human nature. I think it's not easy to understand, but human nature is weird in that way. We don't always do what's in our best interest, but nevertheless, and and it's not that necessarily history is always going to a better and better state. I mean, there have been periods in history where things have been more conducive to the flourishing of human beings, and other periods where it's been less conducive. But we shouldn't lose sight. I mean, when ships navigate on the ocean, they use the stars for guidance, right? They can never reach the stars, right? You will never reach the stars, but nevertheless, you use the stars to guide yourself. Same thing with the free market principles. You have to know exactly which direction to navigate, because otherwise it's extremely treacherous. And you can easily be swayed by, yes, what? Are you impressed by my metaphors?
That is one of, I was going to interject and let you finish later on. Michel is going to change his Twitter handle to the North Star.
No, but so I think, and then the other thing I want to say here about it is that to imagine that we cannot convince the public is a way. It's the same kind of paternalism where, it's just like saying that the public cannot pick their own doctors because they're not, they don't have the the knowledge, and it's true, and it's true. The public will make blunders, and we, I make blunders, we all make blunders, but nevertheless, we can recognize if an idea is good and we recognize it as such, and we cannot find any really compelling principled evidence that the idea is wrong, then that's the direction in which we have to go. And
so
continue pushing and be uncompromising, because the moment you compromise, you muddle the whole thing. Because you will compromise, that means that you will allow special interests to insert themselves, and it will corrupt the whole thing, and then you will actually use your credibility, because you'll say, hey, you advised us to do this, and look what kind of mess we got into. So that's what I say.
Roman, what are your, I'm curious, given your knowledge of what's going on in Ukraine, what do you think the Ukraine will evolve into, given what's happening in terms of their healthcare system?
In terms of the healthcare system, I mean, do you think
there's going to be, one of the interesting things. It's hard to
say anything about Ukraine evolving, because to Michel's point, Ukraine has a huge corruption problem. So it's hard to see where any of this goes. I'm assuming some kind of national health service eventually. But it's, this is something that's decades away.
But they don't they have, I mean, isn't they, so they don't have a national health service right now. They don't have, I mean, don't they have, isn't everyone is on a state payroll, yet you have this flourishing black market, I guess, or I don't know what you'd call it, but flourishing.
State-ignored black market, effectively.
But
right,
to me that brings to mind the example of India, because if you take India as a counterexample, with India, clearly it's not great, but it's getting better, and it's getting better certainly because I think everybody will agree, because of free market forces, free enterprise, not just in healthcare, but everywhere else, so that it's much better now than it was 20 years ago. I mean, you have services that were not, Anish, you're shaking your head.
Well, I think the dark ages.
Huh?
Sorry, I think the dark ages are coming, Michel, because I think every society goes through this, where what you have in India is the wild west in healthcare, where these hospitals, these houses, they buy these beautiful houses, they build a hospital there, and suddenly they say, oh, American doctor trained or whatever trained, or there's plenty of good medical schools in India, but this guy's from the city, etc. And then what happens is you have a massive amount of I mean, my 85-year-old grandmother has been recommended a coronary CT multiple times when she was admitted for a UTI. I mean,
yeah, you're correct. It's the transition, Anish.
Yes. So the transition. No, I'm agreeing with you. I'm saying so the transition now is happening. What is happening? India has now. So people are putting stents in, like crazy. They're saying, oh, you need this stent, otherwise you will die. And of course, it's for stable angina, and they have shortness of breath, and they're obese, and the prices are massive, right? The prices for stents are massive. So what has happened? The Indian government has stepped in and has tried to regulate the price of stents. The most recent thing, because the vast majority of India does not have the ability to pay anything for a stent, is not Medicare, but Modi Care, right? Narendra Modi is the Prime Minister of India, and he's now introduced Modi Care, which means that all, a massive percentage of Indians will now have government paying for their insurance. These things, Roman is right, are incredibly politically popular, and that is the direction that these type of free market systems seem to fall. It's the valley that they fall into. And then the really interesting thing is that then, the United States has always seems somewhat ahead, is what happens in the US, which is you have these systems, but the systems are collapsing under their own weight. The systems are crumbling. And you're getting these massive deductibles and these large deductibles, which means that patients have to pick up more and more of the cost of their care, which the insurance companies want, because that will limit the care that limit the healthcare they'll deliver. That actually creates an opportunity for folks like Michelle and the direct primary care movement, for folks like the Surgery Center of Oklahoma, to thrive in that environment, right? Michelle interviewed a gentleman from Switzerland, and in Switzerland, the copays are $10. Yes. Prices are rising, premiums are rising, but copays are $10. And Michelle very rightly brought up the great point, saying that if copays are $10, because everything is subsidized, everyone that can pay pays, but everything else is subsidized by the government, there's no opportunity for the free markets to work. But the Swiss system is also unsustainable. So it seems like the natural history of this is, yes, there's the dark ages that come. The dark ages being third parties which say, oh, we will take care of all of this and everyone will have awesome healthcare. But of course, we all know that that's doesn't happen. And these things, these systems crumble under their own weight. And I think so. I think the
you have
trend.
To be careful when you say crumble, right? Because we haven't actually seen a system crumble.
Right.
The NHS has been crumbling for 50 years.
Yeah, that's a good point.
It's still around. It's still underfunded. Everybody's in there, from my understanding, still miserable. They have something like 10% personnel turnover. It's insane. But they're still there. Maybe they'll crumble in a year or a decade, and I'll eat my words. But there's no amount of tax money that can be funded into. There's no limit to the amount of tax money that can be pumped into these systems for them to not crumble.
That is right. The pragmatic argument is very difficult, for the free market. It's very difficult to sustain for the points that you've made, or both of you have made. But on the other hand, we can make the system crumble a little quicker, because I like all these systems to crumble, if we, remain true to our principles. If those of us who understand and can distinguish, the way things are moving on the basis of principle, because otherwise, every society is a mixture of free enterprise and state intervention to various degrees. All societies. So it's almost, it's extremely easy. It's always easy, always very tempting when you see something bad happening to blame, whichever ideological side you're not on. So if it's to blame the free market, when in fact the root of the problem is in government and state intervention and corruption and all these things. So I'm neutral in terms of on the optimism. I mean, here I see a few trends, a few optimistic trends, which I mentioned, and they could all vanish, at the stroke of a pen or a decision of Congress or something like that tomorrow.
That's my anxiety as well.
Yeah, I'm completely aware of that. But still, I still think that the proper strategy is to continue to push and not compromise on the principles, and recognize that, in a way, the objections, I'm picking on you, Roman, but the objections that you've made in your paper are all answerable if we understand exactly what healthcare is about, that it's, at the end of the day, it's a relationship, right? Healthcare, at the end of the day, the quality of healthcare is the quality of the relationship between the doctor and the patient. And there's no way that can be subsidized by government, adequately subsidized or regulated, and any regulation and any subsidy of healthcare is going to destroy the doctor-patient relationship. And I want to make one last point here, is that you make the point, and I think it's a commonly made point, that yes, maybe the free market is okay for the commodity aspects of medicine, if it's just replacing hips and whatnot. But when it comes for more complex stuff, then we need government intervention. It's actually exactly the opposite. I'm saying that perhaps you can trust the government with commodity operations, but even then, I mean, they barely can deliver, can run the postal service. So, but perhaps you can trust the government with commodity things. But for things that are very complicated and that are highly personal, I mean, that's precisely the field where you want as much freedom for patients and doctors to sort of find one another, you know.
Okay, so for example, one of the cases I gave was mental health. How do you propose the free market solves this problem of a mental health patient who has elected not to insure themselves? They freely chose not to, or get an insurance that covers mental health. And now that they have a condition, they're progressively spiraling.
Right. So when you say to solve the problem, I'm not sure that the healthcare, free market healthcare will solve the problem, but the free market will take care of the problem. At least, I mean, to me, certainly better than a government, sponsored system will. Now, of course, you can always find, examples where, in a national healthcare system, some people were safe. But I'm saying overall, on principle, it's clear that a free market where immediately the cost of care will be cheaper, and people will have the freedom to choose, especially in mental health, where it's so important. The relationship between the doctor and the physician is so important that in free market people will be able to choose. And if it's very dire, they'll have actually a lot more latitude to experiment, because right now we see, we talk about this with EBM and everything else, it's the push for standardization is really a trend that is that results from the establishment of large healthcare systems, right? So the push for EBM comes from Canada. That's no surprise, right? So mental health will be taken care of, I think, a lot better in a society where there's freedom of action for patients and freedom of choice.
Yeah, I think that's a relatively easy one because the Medicaid population, where there's a lot of mental health issues, the mental health resources are so utterly poor. Right. So there's clear evidence that government-run mental health programs are terrible. So I mean, if the free market just has to do better than that, I think that's entirely possible.
As terrible as they may be,
yeah,
scarce as they are, they do exist. They do exist, and they are available. That's important.
Yeah, but they would still exist in the free market. I mean, you would just have to. Michelle's, somewhat speculative, but I kind of believe that, again, if you put more dollars in the pockets of psychiatrists rather than these large Medicaid managed programs, what people, look, government-run healthcare is a challenging beast. Look at Medicaid, right? 2015 Medicaid, $550 billion. I think in that same year, $600 billion went to the military.
Large amount of money,
right? I mean, we spent a massive amount of money on Medicaid. Where are those dollars going? I am getting paid $40 for a follow-up visit on a Medicaid patient. Yet the Health Partners plan down the street, right? I looked up their revenue. They're a nonprofit. $1 billion they're getting paid to manage Medicaid. Where is the money going? They have this massive building on Market Street, beautiful building. I mean, 50,000 square foot on Market Street. What is that costing? Why is the Medicaid? Anyway, so my point is, if it's relatively clear to me that whatever dollars that would be allotted by whoever would be far more efficiently allocated by the free markets than by the government program. But Roman, let me make a point. Let me ask Michelle. You and I can tag team Michelle on this one. Michelle, how do you answer this? How do you answer the moral hazard argument? How do you the problem is that somebody's going to smoke for 50 years, somebody's going to drink alcohol for 50 years, and they're going to end up with severe liver disease. They're going to end up needing a liver transplant. They're going to end up with squamous cell carcinoma, requiring a very complex surgery, flap. 4 or 5 days in the hospital. And this happens to, the rates of obesity, the rates of smoking, the rates of alcohol use are much, much higher in a relatively indigent population, folks that are hanging around the 40% of the federal poverty level or less. It seems to me unlikely that group of folks are going to be able to marshal the resources to be able to pay what's needed, even if healthcare costs were much less than what they are. Is that a concern for you? Like, how do we deal with that?
Right. Well, I think first of all we should be clear that if I have my libertarian healthcare paradise, free market healthcare paradise, I would actually necessarily have a libertarian society paradise, and it wouldn't be just free market in healthcare and elsewhere. The same kind of government intervention and cronyism that we see throughout our society. It's most acute in healthcare, and because healthcare is so important and personal. So we feel the sting of government intervention, and we pay the price for it most readily in healthcare. But it's present everywhere, throughout society. It's present in banking. So you have banking cartels. You have cartels at every level. And that's really, you have the military industrial complex for sure. So all of this is impoverishing society greatly, right? So one thing to do is to deal with the prosperity and the flourishing of human beings in general, right? Which I believe a free society is geared towards. So number one, that's a more general answer, and it may not be.
So you think there would be fewer? You think there would be fewer people?
Correct. I think in general it would be a society. I mean, on principle, it'll be a society that's where human flourishing is greater than in these welfare corrupt nanny states, which are what Rothbard called the welfare warfare state. That subsidizes both warfare and welfare at the same time. So in a free society, you wouldn't have that, and you have much fewer people. We have to accept the fact that there is always, inequality is in human nature, right? People, Roman, you put these examples in your paper, right? People who are born with genetic defects, or terrible diseases. That's true. There is inequality, and it's the state of nature, and we have to accept it. But again, local solutions, personal solutions, solutions from people who love so the guy who's drunk and poor and has liver disease, we need to love that guy, right? Personally, not appeal to tax-funded programs to go and take care of him, but actually organize ourselves. So we do this in our neighborhoods.
I think that's a very rosy view of human nature as well.
No, it's not. It's not. It's the only view. It's the only view. It's not. I'm not saying that it's going to happen, but I'm saying that's where we need to move, right? So I'm not saying that's going to happen, but I think that's where we need to move.
How will love give him a liver transplant?
Well,
meaning the thing is, Michel. So,
but a liver transplant is not necessarily what he needs, because if he gets a liver transplant, he really gets it at the expense of some kid who can't go to college, because that money is not really, it doesn't grow on trees, right? So if right now the guy is getting a liver transplant, for sure that money is coming out of the pocket of somebody else, right? And that's not fair. That's not right either. So we have to take that into account. I mean, right? And so
no, it's that's what I mean. I don't know if Americans are rugged enough. I'm certainly not rugged enough, because obviously the one thing that third-party payment freed up, Michel, is it freed up a massive amount of dollars that people went after. And so,
correct.
Would you have? I don't know that you would have a lot of the. I don't know if you would have this type of. I don't think you'd have the type of innovation.
Being as it may, to me,
I have trouble believing.
I'm more interested in the. Right.
Yeah, you have CAR T. That's. I know it may not be $500,000. It may actually be $250,000. But you have massive liver transplant programs being set up all over the country, right? And no doubt, there's a massive number of people that are still alive today. And again, of course, you have kids that are born with liver diseases and who are living normal lives now, because I don't know that without turning on the tap as you did by opening up third parties, essentially third-party payment essentially created a massive
subsidy
that people could tap into.
Correct.
So how, so that is a...
Right, but I avoid the consequentialist argument, because to me, the more important thing is the moral question. I want a socially just society, and these societies where you massively subsidize X, Y, and Z, of course, you can always find some good coming out of the massive subsidy, right? But
I think that's probably where we differ primarily.
It's unjust.
We differ in terms of our starting points. I respect the moral argument and that we want the optimal solution. My starting point is we live in a physical world with, second degree, third degree effects beyond what we want to happen and what should happen. And the way I see it, we live in a world where 50% of the population now has chronic disease. In the short run, it is now beneficial for them to vote for single payer from a financial perspective. Yeah, Milton Friedman had one talk where he really changed the way I view democracy. He has this thing he called, I think it was called Director's Law, where the idea that the rich rule democracies is just stupid. The optimal solution is you have the middle 50% ruling, taking the money from the top 25, transferring them to the bottom 25, taking a big cut along the way. Sort of talking about your Medicaid point, about where is all this money going? That's where it is going, into the middle class. And the reality is now we have a world where 50% of the US is chronic disease. It's only going to grow. The numbers indicate it's increasing on every front except for maybe smoking, which seems to have flatlined. But, you know, e-cigarettes are on the rise as well. So we'll see how the kids pick that up. But the way I see it is single payer is inevitable, or at least some form of it. So what we have to decide, and this is my starting point, is how do we play in this environment where single player is going to happen? And my proposal is, here's the points where free market is either untenable or debatable, focusing primarily on the idea of patients having a hard time of actually shopping and choosing, which I see as essential to a market. And my idea is that if we are willing to sacrifice, at least, we have to make sacrifices somewhere. Make sacrifices where we don't care as much for places where we do. So here's my proposal. Would you be willing to sacrifice financing in exchange for free market, extensive deregulation on the provider side?
What do you mean by financing? Sacrifice financing, meaning
you're basically giving up the private payers.
In exchange for what?
In exchange for deregulation. Extensive deregulation on the provider side. We get rid of certificate of need. We get rid of.
But that to me, that is the much more unrealistic. That to me is completely. I mean, how would a single payer system move in the direction of deregulation? That to me is completely unrealistic. I mean, the more you centralize,
the way it works
the more you increase the regulation. And
the way it works is you end up with a system where the single payer provides a fee, and the providers can either accept that fee or they can charge more and accept cash in the meantime to make up the difference.
I think that's all unsustainable. Meaning it's unsustainable. I mean, the Swiss have a very similar model to that.
It's actually, I would say it's different. It's basically ACA on steroids.
Right. But meaning you would. Oh, so I see. You would have the ability to. You don't have to opt out in order to take cash payments. You're saying you would be able to balance bill per se. Why would that be? Why would that be politically acceptable or pragmatically acceptable? I'm not sure, and I don't know why anyone would be more in line with that. But I think what's wrong with a system where you have a certain portion, like Michelle can be the North Star where everything is or nothing is covered, but then how about we have a system where you cover certain things, but you leave. 90% of healthcare does not have to be covered. This whole nonsense about like chronic disease, 50% of the country is chronic disease. 50% of the country does not need to be chronically managed. By folks. You don't need. You can make primary care in large part.
But we create chronic diseases at the drop of a pen. A committee, the hypertension committee gets together, and the next day you have 6 million hypertensives that are created.
Right.
So all of this is artificial.
What's wrong with having a midway point where you say that you have you cover catastrophe. You have some national system that covers catastrophes and covers things like transplants and other massively high risk catastrophic stuff. A catastrophic only plan. What's wrong with that? And then everything else is so essentially we're talking about we're talking about essential health benefits, and we're saying that your essential health benefits are very small, and then everything else is cash pay. That would still be a more workable system than what we have now.
I don't think so. I think it's impossible to articulate exactly what catastrophic means. You're right. I mean, you're gonna pay for the mastectomy, but you won't pay for the mammogram. I mean, it doesn't mean where do you draw the line? You really can't. You can't define what catastrophic means. And then if you define it, then people will adjust to that. Everything will be a catastrophe, right? I have a catastrophic, rhinitis. So that's sort of if you go through the motion of trying to really make it explicit, then you really can't do it. Although I know there's some insurance plans call themselves catastrophic, but really what it is, it's a super high deductible, generally speaking, and only covering hospital care. But they can work just because the system is set up that way. The moment you make this sort of a national model, then everything will adjust to this new reality, and you have the same kind of...
Michel, don't you think the free market wants a third-party insurance plan? I mean, the free market comes up with workman's comp. The free market comes up with, in the car insurance world, the free market comes up with and defines catastrophic, right? Meaning the car insurance industry has a catastrophic insurance plan, essentially, right? There's no difficulty deciding between oil changes and, totaling your car.
Yeah, it is, because the car is a machine, whereas a human being, there's an element of behavior. That's what you can't really compare. So you can have a catastrophic car insurance, but you cannot have a catastrophic health insurance, or even health insurance per se. Health insurance is really it's a ridiculous concept. You can't really insure health. So nothing works, and in a free market, it would be it would never have seen the light of day, right? So we know by if you study history that the whole concept of health insurance is a government contrived project. So I think I'm going to stick to my guns here. Roman, I appreciate the opening and the proposal, but I'm going to stick to my guns. And I think we need to wrap it up.
Yeah.
Very good.
But
Roman, what? So
final thoughts, Roman.
Final thoughts, Roman. What? So you're still sticking to that? This is.
I still stick to the guns that I agree with Dr. Akkad, and that I think that Dr. Akkad's ideas are either impossible or at worst going to get us into bigger trouble than we should be if we ignore that political side.
Yeah, I try to avoid using the we, the collective we. So, but the point is well taken. I mean, I can understand why people would want to be, sort of jockey the best political scenario moving forward, and that's really something I have zero interest in. But I will concede that. I will concede that point.
Here's hoping, Roman, best of luck in medical school, and I'm betting you that the more you're surrounded by the left, your leftist colleagues, that will actually pull you to the right.
I mean, don't misunderstand me. I'm completely on the right, 100%.
I know. You will just be so frustrating. Annoyed. Yeah, you'll be so annoyed.
You've been very, very kind and brave to show up on this. We trapped you here, on our show, and you knew full well that we were going to assault you with our objections. But you've been very, 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 a very good sport doing so. And we look forward to chatting with you on Twitter. And we'll have your Twitter handle on our show notes, which you want to shout it out here, because I can't remember offhand.
Sure. It's just at Zamishka, Z-A-M like in Mary, I-S-H-K-A.
Okay. Right. Roman, thank you very much.
Thanks, Roman. Thank you for having me. Great talk.
All right. Take care.
Bye.
Bye-bye.